Welcome everyone to Where Do Your Sleep Patients Come From? It's right at 8 o'clock by my watch. Are you with me, Dr. Drake?
I am. Can you hear me?
I hear you great. Thanks everyone for taking the time out of your evening to learn a little bit more about dental sleep. We hope this will be beneficial, and we're going to try to run on time so that we can have plenty of time for questions at the end. So I think we go ahead and get started. What do you think, Rich?
I'm ready. Let's get after it.
All right. Well, let's see if we can get this thing going. First, just a little housekeeping here. We do have everyone muted, and if you look over here where there's a questions button, and yours may look a little different than our view here, where I have the pointer here, you click on that and put your questions in there. We'll try to get to them as we go. If we don't get to them as we go, we'll get to them at the very end, but we'll get to your questions. Another thing you can do, so you'll have a question box pop up, is you can see these little raise your hand icons, and we'll keep an eye on that. And if you have a question, then we can certainly would encourage you to your questions. Raise your hand, and we'll, at an appropriate time, unmute you, and you can ask your question. So we really appreciate your participation in this. That's me on the right side as you're looking at it, Dr. Guy Yatros, and Richard Drake is on your left. That's my partner. We've been doing this a long time. We've been doing it a long time with Keller Labs, and we appreciate their support and helping put on these webinars. And this is what we do. It's all we do, and we hope that we can help your practices get to doing more of this. Rich, you want to tell them about our mission statement of Dental Sleep Solutions?
Yeah, we're the most trusted, innovative, and customer-focused provider of solutions in dental sleep medicine, period. You're not going to find anybody else out there anywhere who does what we do in the ways that we do them. And we are here to help dentists do this and implement this and to save lives.
Fair enough. We'll talk more at the end if you have questions about how we can help you in your practice, but we help in all the ways, the challenges that you may come across. We'll also put these slides up at the end. The next module, write down the date, 9:30, same time, and we're going to talk about testing, because today we're talking about screening, and then the next step in the process is getting your patients tested. We'll also put this slide up at the end as well. This is some hands-on meetings, courses that we're putting on, and again, we'll have that up for a little bit longer at the end if you are interested in attending any of those. But we want to really get right into it without delaying a whole lot. And you know, what's the purpose here tonight, Rich?
We want to help you guys find some sleep patients. You know, we deal with dentists all day, every day. Keller Lab, we're constantly in communication with them about, you know, what kind of questions do you get? Where the dentists are asking all over the country, and all the time it's, you know, where do these patients come from, and you know, where are you in this now? Are you just getting started? You just, you know, don't know anything? I think of that old fat German guy, remember, in Hogan's Heroes, we go, I know nothing.
Schultz.
And yeah, Schultz. Yeah. And some of you are getting started, and you know, we want this to be applicable to all of you here, but the purpose really is to help you find the patients that are in your practice. We'll talk some more later about outside things and things like that, and so we talk about the purpose. What's the process that we do that through?
Well, and that's, you know, I think if we can define that this is what we want to do, a lot of people fall short in the process. And if you believe in helping your patients, then you've got to get going doing this. A lot of dentists want to do this. They kind of get started, and it's really not that complicated, but it takes a commitment. And we'll give you some tools on how to do this very easily in your offices and the processes. And then, you know, the payoffs are huge, because that's what we're looking for, is the payoff, helping our patients, helping our practices financially, helping our staffs and everyone enjoy what they do more. So this is the beginning of how you can grow your dental sleep practice, and it's we try to break things down into steps for you. And today we're going to talk about the first two here, about identifying the patients who have susceptibility to sleep disorder breathing. How do we do that? And then getting them to acknowledge they may have a concern, and then we need to have a readily available test for them, and we'll talk about that at the next webinar. So we're going to concentrate on the first two. here today.
So we're going to walk you through this process. We know some of you are getting started and others that have been doing it a while. And we still have to realize that as dentists, these people are walking through our doors every day. And we have to have some system in place for how to do this.
Absolutely.
How many people are out there, Guy? I mean, are we looking for, that one patient out there that's got sleep apnea?
No, I mean, there is not the one patient. We're going to go into prevalence right now, as a matter of fact, and there are millions of patients who don't know they have this problem. And I know this is a little bit overlap of some of our other webinars, but it's worth repeating that this is a significant problem that we as dentists can help. Look at the numbers here. I mean, 1 in 5 of your patients, adult patients, has at least mild apnea. So that's one of your, if you have a full day of hygiene patients that are adults, at least one of them has apnea. And look, the red part here is the people who don't know they have it. And the ones that know they have it, most of them.
And then even the diagnosed, there's a big chunk of those that aren't treated. So, there's literally 1 million people in the United States every year who get a sleep test, understand they have sleep apnea, they're prescribed CPAP, and they will not use it. So even if we just picked up the crumbs, there's a whole lot of this out there for all of us. And one of the points that we want to make sure you guys understand is as you start this screening process and looking for these patients in your practice, you need to understand that you're going to uncover a lot of people who have already been diagnosed, but the majority of them have not, and it's millions of people.
Millions, and we as dentists are in really one of the best situations to do this. So
when you find these people, you just sell it to them, don't you, Guy? You've been selling dentistry your whole life.
Yes, CPAP's horrible, and we're going to save your lives, and these pieces of acrylic are wonderful, and we're going to sell them the case, right?
You show them how pretty they are, and
that's kind of to show you that's not really what we do, and you as dentists know better than this when it comes to pretty much any of the things that we're going to do as dentists. We want to help our patients, but people don't desire to take care of something until they're aware of the problem. They have to be aware that there might be an issue here, and that's what we're going to speak a lot about over this hour is making patients aware, identifying them, and then as their awareness goes up, any reasonable person wants to be healthy. I think that's a fair statement that unless you're insane, you don't want to be healthy. We choose to be unhealthy because it's easier or whatever the reasons are. But if we start with the premise that any reasonable person would prefer not to have all the problems that apnea causes, then we just have to help them become aware that they may be at risk, and then their desire to fix it will go up, or desire to look into the possibilities.
And we're going to give you some verbal skills tonight as well that will help you in that process walk those people down that path. So we don't like to use big words like apnea and hypopnea and things like that. So we're going to give you some verbal skills to do that. But obviously we want to start with the lowest hanging fruit. And those are the people that are walking through your door every day. So don't run off and buy, $100,000 worth of advertising or something like that. You really start with the patients in your office. And the best reason for that is it's the quickest way to get going in dental sleep medicine.
Yeah, identifying the patients. When we started this over a dozen years each ago, a good deal more than that now it seems like. This wasn't the case because it was harder to get patients tested and so forth. But now we help train dentists. We've helped hundreds of dental offices get going in dental sleep, and what we do, if we start with the patients, that right there you have a trust relationship with your own patients. They're coming to you because they believe in you, and if you believe you're there to help them, then identifying these patients in your own office is the quickest way to jumpstart your dental sleep practice, and it's the right thing to do. If you don't start screening, it takes a lot longer to build a dental sleep component to your practice. We keep calling it a dental sleep practice. Let's be clear on that. We don't think that you have to just do this any more than you just do implants or veneers or Invisalign or anything you do in your practice. But if you want to have a component of your practice that is dental sleep, if you want to start marketing, and we'll talk a little bit about that, or getting medical referrals, that's a lot longer process to get going than the starting right at home.
And it's something that you should do and you should develop. But I want to mention here too, Guy, those kind of Monday morning blues. We teach a course on Friday and Saturday, and you're so pumped up, man, and you get back there and you start. You've got a few patients within arm's length. Your hygienist husband snores and doesn't sleep well, and these people are all over our practice and our staff. But we see this kind of come to a halt after you kind of treat those people close to you. And the biggest reason for that is they just don't have a protocol in place to screen their existing patients that are there. So take that to heart. We get in front of a lot of offices. We talk to a lot of dentists every day. And this is the first cog in that wheel of getting going.
When I do live courses, and it's a little hard to interact over the webinar with microphone issues and such, and that's why we, for the people who've just joined us, we have you muted. If you want to put a question, we'll be happy to answer it. Raise your hand if you want us to unmute you for a moment for a question. But when we do this live, I always ask, how many of you all screen for oral cancer? And everybody raises their hand or should raise their hand. And how long does that take? Couple of minutes, 5 minutes, and we do that because we care about our patients, and it's an oral problem that we're looking at. And how
many have you found, Guy, in 20 years?
Well, personally, I don't know, probably less than 20, I think. But what I do when I ask this question is the most I've ever had is 4 in 1 year, and we lecture to thousands of dentists live a year, and that's the most anybody's ever said. I found 4 last year. You'll find 4 patients with undiagnosed sleep apnea likely in your practice next week, in the next 5 days, if you do a good job of screening.
I was going to say Monday morning.
Well, you might, but the numbers, and if we care about our patients, it doesn't take any longer to do implement an active screening process for your patients. So these are some forms and things that we'll talk about. We're going to talk more about what you as a clinician, why we as dentists really have a keen eye for this once we start understanding what we're looking for. We're going to talk about reviewing the medical history. You need to ask questions.
These are the best ways that we found, okay, for those patients in your practice. And we're going to talk about medical referrals later and marketing and all those types of things that you can do. But think about the people just walking through your doors every day. We're going to talk. We're going to give you those tools tonight. You're going to have a screening protocol, something that you can do. We're going to give you clinically some things that you can look for so that you can see, and then we'll talk about the other things, ask them questions and some of that other stuff. But tell me about, just a screening protocol and what would you look for?
Well, in a little bit, we're going to talk kind of how we want you to think. And it's kind of like you start looking for caries and they jump out you, periodontal disease, all these things jump out at you if you're used to seeing them. So we'll talk about how to think in a little while. But literally just the screening process is as simple as coming up with a questionnaire that you hand to your patients or include with your new patient forms or that you give to your hygiene patients. And basically the purpose of that is just to say, hey, this person is at risk for sleep disorder breathing. And if you get a good questionnaire, it will identify a lot of the people who are at risk, and it can be a matter of just a few minutes of a patient filling something out. That's the easy part. The harder part we'll talk about a little bit is after we've identified the patient is getting them to acknowledge this, voicing the concerns over the problem, getting them to go up on that awareness scale is the challenging part. But if your heart is in the right place and you believe that this is important, and don't let some of the things that have happened to some of our offices have to happen first. We've had people who we screened and they didn't get tested, and we find out they had a heart attack in the middle of the night. These are all true stories that have happened. Don't make that be what it takes to make you realize how important this is.
Yeah, and you don't have to create your own forms to do this.
Absolutely not.
Forms out there, and we're going to talk about that. But remember, there are literally hundreds of patients within your practice right now, okay? And a big part of this you have to understand is that it's not just you, the doctor. It's important that your staff gets on board and that they understand the seriousness of this disease. And when we look at how many people have this. It's really an unprecedented public health problem, crisis that we're about to face here in the United States. And again, we talk about meaningful work. We talk about doing the right thing, and these people are walking through our doors. So let's talk, Guy, about how we can start to find them.
Yeah, and we say it's the right thing to do, and that's why we should do our procedures in our office. We should do it because it's meaningful. But you know what? If you're not doing it and you're not involved in this, you are letting some money just go out the door. There's financial gain to be made here, and that shouldn't be our only motivating factor. But it's another reason yet to do this. So getting involved is as simple as let's give somebody a questionnaire. There's 3 of them on the screen. Originally, we were going to go through all of them, but we only have an hour. And you know what? This information is readily available on the internet.
Yeah, you can Google any one of these, and they'll come up with the form. You can take that form and put it on your, add it to your existing forms in your practice that you use, add it to your letterhead. But again, it's a commitment from you and your staff to this process for trying to identify these people.
Right, and it's just a quick way to say this person's at risk, this person's at moderate risk, this person's at low risk. Doesn't mean all the low-risk people don't have apnea, but let's address the ones that are at high risk first. If we can start doing that, we're going to make a big difference. The Epworth is probably one of the most popular one. That really just tells that the patient's sleepy or reports that they're sleepy. That combined with some of the other ones we just had on there are a really good start if you want to use paper forms. The key to this is that everyone that comes to your office is going to be screened. It is your obligation. So let's screen them with the paper forms, tablet form like we use in our office. And one of the things the patients say, what is this all about? When you're handing them the forms to fill out, just look, we're updating your health history. And we want to get a few answers to some of your health questions on here. Don't tell them, hey, we're going to try to see if you have apnea by filling this out. People don't like to be labeled with things, especially if they don't know they have them yet. We don't know they have this yet. So let's just say it's business as usual is what you need to remember. I think when we get insecure about what we're doing and we act like it's a big deal, the patients sense that. If this is just something that we do every day, I just don't have patients who give me any objection to filling out these forms. Our goal is just to gather some information and then identify, hey, these people are at risk. It's just we're making it sound simple because it is.
I think you hit the nail on the head there too, Guy, because you as doctors who are on here, and hopefully we have some staff on here too, have to understand that you personally are probably not the one implementing this and doing this. So it's very important that the attitude of that person who is either handing them a paper form or a digital tablet screener or something like that is business as usual, and we're doing this because we care about you. We did this in my office the other day, Guy, and we handed him the tablet, and he started down the Epworth questionnaire, and he said, "Is this about sleep apnea?" And the staff member said, Well, that's part of, certainly what we're screening for through doing this. He said, "I already know I have sleep apnea. I've had 3 sleep tests, and this is a guy that's coming to the practice for 15 years." So you're going to find patients who already have the disease as well, and we'll talk some more about that.
Right, and to clarify, that's in the practice that that you share space with is the general dental patient that was coming in that you were screening. How we do this in our offices is we use electronic records and we use a tablet to use a screening process. There's other programs out there that do this, but essentially we put the name and so forth in here, and then we have an Epworth sleepiness score that they just touch on the tablet.
So if the patient's doing this on a tablet, do you actually hand the tablet to them
right.
and let them do it?
Just like the paper form, hey, we're gathering some additional health information. Do you mind filling this out while we're getting the room ready to have your teeth cleaned? And they just tap the answers to this. Again, nothing that Dr. Drake or myself invented, the Epworth Sleepiness Scale. We just basically digitized it here with our DS3 software. There's some other questions that are from the American Academy of Sleep Medicine's screener forms that that they answer yes or no to. And you know, again, it's really not about the form. I like this digital format mostly after we get through the last page, which are comorbidities, when you'll understand where these fit in a little bit more in a moment. My favorite part about this digital a screener over paper is the patient has a computer basically in their hand that says, oh, I'm at severe risk, and we intentionally laying a dog laying on their back, you know, or something. They're open to what you're going to say next. And if you say you're at risk, and then the patient hands the tablet back, and the auxiliary or the dentist fumbles around, well, I don't know because this computer says so, or, you know, you've got to educate yourselves a little bit, and you got to know, well, look here in this scenario, well, you've got an Epworth of 19. That means you're sleepy. The number one reason for sleepiness is airway problems, and boy, we should really figure out what's going on with that. Or we can also look at some of the comorbidities down at the bottom. They have high blood pressure. Well, we're going to see in a few moments that over a third of the patients who have high blood pressure, it's because they're having airway problems. And notice I'm saying airway problems, not you have apnea, Mr. Smith. I'm not saying that. I'm saying I'm worried that your airway's closing because of these reasons. So
yeah, I like that, guy. That sounds good. But the point is, with the DS3 digital system, we've made this so easy that you just literally click a button and it tells you. If you decide to use one of the other forms, then you just need to be familiar with that, and you need to be familiar with why that person's risk is severe. So again, what we're trying to do is assess a patient's risk for a sleep and breathing problem.
Absolutely. And forms, tablets, be prepared to answer their questions. And it really, it goes that well when you're prepared and you're confident in what you do. I've seen Rich go into offices where they're like, we're just not doing well screening. The patients don't even know him. And he goes in and starts screening the patients, and next thing you know, he's got 5 of them signed up for a sleep test. And it's just a matter of understanding how important this is. Flagging the people is the easy part. Making sure whoever is going to discuss that is educated enough to get them to understand the importance of the next step, which is usually getting a sleep test if they haven't already had one.
Right, and again, that's our next webinar we want you to tune into, but for now, and I appreciate that compliment, Guy, if that was a compliment about
it was.
But we are, as dentists, I mean, you know, who out there is in a better position to do this? I mean, the last time you went and saw your primary care physician, Guy, did somebody ask you, hey, how are you sleeping?
No.
You know, are you feeling good? You know, we had a guy come in the other day, and one of the things we'll go through here today is just simply ask questions. And the guy's in there to get his teeth cleaned in the office where I am, and the hygienist says, man, you don't look too good. You know, he says, I feel terrible. Are you sick? You got a cold? Man, I'm just not sleeping well these days. And the guy left, and he was scheduled to have a sleep test done. So again, you know, we can ask questions. We have different ways to screen. So we gave you 3. Let's review those real quick, Guy. The Epworth, what were the other ones?
Stop, bang.
Stop, bang.
Berlin.
And the Berlin. So you can Google those. They will give you that online. You can cut and paste that into your letterhead or your own forms and use those. DS3 has a digital screener. So besides the screening part, what are some of the things that literally we can look at as we do exams and, clinically the things that we can observe that might mean, remember, we're trying to look for people who are at risk for sleep and breathing problems.
And this is one of the reasons I believe dentists are in the best position of any other healthcare provider in the country. We see our patients more than the primary cares do. And then furthermore, we understand, we work in this environment. We work around the tongue. We understand craniofacial anatomy. And so some of the clinical observations that we're going to speak about right now, you as dentists are very aware of. You just got to start seeing them through the eyes of the airway. And we can start by just looking at our patient's neck size. I love measuring patients' necks in a general practice office. What happens, Richard? You go into an office and you take out your tape measure and you say, I'm measuring the neck. What happens? What does the patient do when you do that?
What you want to measure? What? My neck? What?
Yeah.
What's that got to do with anything? Absolutely, it starts a whole string of questions. And again, this is what we want to do. We want to engage our patients in a dialogue. So just the simple process of measuring their neck, and you see here, men with necks greater than 17 inches and women greater than 15 inches puts them at a significant risk for sleep disordered breathing. And we don't have to weigh people at this point when we're identifying people. Now, we do like to have, a guy got me into this a long time ago, putting a scale in my office to weigh people because it gives them a lot of accountability about that type of thing. But at this point, I don't think it's a good idea to weigh them, but we can certainly clinically observe who has a problem.
Right, because as you're going to see, obesity, we all are aware of that. Anyone who's obese is a much higher risk. But let's don't only look at that. I think that's one of the shortfalls of the medical community is people who aren't obese who have apnea are often overlooked. So certainly we want to look at neck size, which is related to obesity. And measuring the neck, I can't overemphasize how just the process of doing that and being ready for the questions, being ready for that dialogue is really key.
And most men know their neck size because we buy shirts that way, and women don't. So again, it's kind of that wow factor, isn't it, Guy? Rather than saying, hey, do you know your neck size? If you actually get a tape measure out and do it, it makes a big difference. And, of course, the tongue is one of the biggest problems most of us have. It gets us all in trouble because we talk too much at times, and we just look at the tongue and we talk about we'll talk about different ways that we can classify how big the tongue is in there. And one of the things that we see is we see the teeth making impressions on the tongue itself.
There you go, scallop tongue.
Yeah. And that's just a tongue that's either too big for the maxillary arch that it's trying to fit in, or the teeth are too small for the tongue, right? And we get that when somebody opens their mouth and you see that. This is that same guy that you didn't want as a state board dental patient, to do a crown on number 18, because when he opens his mouth, his tongue covers all of his teeth on the bottom. And again, we're looking for things that clinically you can observe every day in your practice that will mean this patient is at risk for having sleep disordered breathing.
Yeah, I'm going to back this up for a second, and just to put an exclamation point on why we're in a good position for this. We could show this slide to a bunch of physicians, and I don't know that they would know if that's a big tongue or little. They're not working in it every day. And if you see number 3 up there, this is my patient from years ago, and when we saw that old amalgam, we always had to crown that tooth. And when I crowned that tooth, what was Rebecca's biggest challenge, because it wasn't mine, it was holding that tongue out of the way. And there's your sign. When your assistant is struggling to keep the tongue out of the way while you're prepping an upper tooth, red flags should be going off in our minds, because that's a muscle that tongue is that's going to fall back into the airway when this patient hits REM sleep. So it just really puts an exclamation point on the fact that dentists are in a position to really see this, because we work in this environment every day. So when you're struggling to wrestle the tongue, it should be literally my team, when I had my restorative practice, would be like, that was just a big red flag. We knew that person was at risk for sleep disordered breathing. What's this Mal and Patty?
What's another way that the anesthesiologist came up with this a long time ago, to look at the ease of intubating a patient. So, class 1, I can see everything, all the way down to class 4 where I can't see anything. And I think we have a picture of that. And they're just trying to look at how easy it is to intubate someone. And in the DS3 software, you have pictures of this and you do this. But again, this is just something that you're looking at. So when the patient opens and they stick their tongue out, on the far left side of class 1, I see everything back there. And then I see just a little bit of the tonsillar of the arch in the back, and then I see none of it, on the far right. And it's, again, this is where we work all day, every day, and these are the things that we see.
This can also help with your verbal skills. What I did when we're screening patients in our practice in the past, we would show them these pictures ahead of time, and we would take this photo with their digital photos like we would all the rest of their photos, and we would explain to them the relationship between the size of the airway and this picture. We're concerned because of the other reasons, and then you'd ask the patient where they were and let them select. Wow, I'm over here, and then just be quiet when they say that. I'm over here. You tell them the story about the anesthesiology, the relationship to the airway, and when they say I'm over here at 4, then if you just be quiet and don't say anything for, he who talks first loses, the patient will say, well, what does that mean? And then you say, well, it means you're higher risk for airway problems, and we're trying to direct the conversation towards them understanding the need for a sleep test. That's the whole purpose for our undiagnosed patients. We've come a long way in bruxism, and we could do a whole day and a half probably on this subject, I would think, however long anybody wanted us to talk. It's a very engaging subject. Do we think about bruxism differently now, Rich?
Yeah, we sure do. We've read a lot on this, and like Guy said, we're putting together some pretty neat lectures, and maybe one that we'll consider doing a webinar in the future. But we think it's related to the airway and the airway closing down. So when we look at people, again, clinically, excuse me, we're just trying to get an idea of, do these people have airway problems? And we see tori, and we see these non-carious cervical lesions, whatever we want to call them, abfractions. I'm so old, Guy, I had to put a gold foil in that thing. So I don't think we do that too much anymore. But again, it's something that we look at. We're looking at the tongue, we're looking at the teeth, how worn down they are. One of the things that we really like to do is to palpate the masseter muscles. And we see people who have worn dentitions like this, and it doesn't necessarily mean that they're actively grinding their teeth right now, as opposed to very masseters that are Olympic size caliber, that type of thing. So we want to start to put all of this together, and again, we're just clinically, what are some of the things we can observe to assess risks of patients?
Yeah, we're not saying everybody who grinds their teeth has apnea, but it puts them at higher risk. If you look at Krieger, this Krieger Dement book is the guru of sleep book. It's the book the physicians all read for their board, and it reports 3 times the amount of OSA in people who are aware of grinding their teeth. So, when we see this, it's another red flag. We're going to put a bunch of red flags up at the end that you should start thinking about when you see your patients. I saw 2 patients today who had OSA and nocturnal GERD. They don't have the GERD during the day, gastroesophageal reflux disease. In other words, the stomach acids coming up, from the stomach into the esophagus, and eventually makes it, in some cases, to the mouth. And then we see the teeth that look like this in the slide here. This isn't just from grinding their teeth. They may be grinding as well. But when you see this acid wear of the teeth, we got to think about GERD, because a lot of the patients don't know they have the GERD. These 2 patients did. And why is that? Why do we have GERD? And I can tell you this, we treat the apnea with the mandibular advancement device, and oftentimes nocturnal GERD will be alleviated, completely eliminated, or at least improved. And what's the relationship there, Rich? Do you want to explain how the acid and OSA are related?
I have no idea.
You have no idea? Well, let me explain.
You think about, as you're sitting there now watching this, some of you are probably on your back porch watching the sunset, and some of you are eating dinner or whatever, and again, we appreciate you spending your evening with us. But if you try to breathe in and you close your mouth and you plug your nose, you feel your diaphragm, come up. We're trying to create this, increase the negative pressure in our abdominal cavity so that air enters our lungs. And when we do that, and our airways closed, we're to get more pressure in our lower abdomen. Our diaphragm pushes up, and it pushes that acid up into the back of our throat. We can get Barrett's esophagitis, which is a precancerous type of thing, and this can be a serious thing. People die from that. And one of the things that I want to point out, Guy, is if you're in a restorative course and they show something like this, they talk about restoring those teeth, and they never talk about sleep disordered breathing, right? So we don't want you to fall into that category. We'd love to have you restore all these teeth, but at the same time, we'd certainly like you to get this guy tested and see where.
Yeah, and if you look at Krieger's book again, twice the prevalence of GERD in people who have OSA. So it's a yet another risk factor when we get to our red flags coming up. Now, dentists certainly understand retrognathia. I mean, I think we see this. I don't know that the MDs are as attuned to this. When I speak to MDs, oftentimes when we talk about angle classification of occlusion, they just seem enthralled with that type thing because they just don't get any training in medical school. I had one of the fellows in my office today. I helped train the medical fellows that are going through the sleep fellowship, and she said they have about a day or less on dentistry. So they just don't understand this. But can you see how this may affect the airway? People who look like this, who have retrognathic profiles, are much more prone to having collapsible airways. And so we as dentists can see this, and boom, there's another red flag. Do you know any other red flags of people that you know that you're close to, Rich? How about this guy?
The opposite, it's true when we look at that and we think, that mandibular plane angle and the long lower face height and things like that. So, these are things we look at. If you contrast that handsome guy there with somebody like John F. Kennedy, John F. Kennedy had a very short, square face, and these things affect how our teeth and our tongue and our jaws, etc., fit inside our skull, and which affects the soft tissue in our airway and things like that.
Right. So long lower face height, retrognathic profiles tend to have more prevalence towards having obstructed airways.
And you don't have to be a genius to figure that one out. I mean, my God.
How's the air going to get through that?
How's anything get through there?
But I wonder, before I started getting involved in sleep disorder breathing, we just looked back there and we noted there wasn't any cancer back there. Well, while we're looking at for oral cancer, let's note, does the airway look open? I mean, this is going to be a problem for this person when they're asleep and all their tissues are relaxed or paralyzed in REM sleep. So
that's going to be a difficult patient to treat, regardless of how you treat that person. And I'm going to throw in there too, Guy, that we have to remember as dentists that sleep disordered breathing is a multi-level disease. It's not just what we see in the mouth. It can start in the nose and it goes all the way down, to the middle of your throat, so to speak. So we have to remember that. There is an adjusted neck circumference that we can look at, and we measure the neck in centimeters, and then we ask about hypertension, habitual snoring, and if they clench most nights, and then we add, a few points to that, and if we get anything over about probably 45, 46, 47, somewhere in there, we start again to say, you know what, this guy is at significant risk for having sleep disordered breathing. And again, some of this has to do with the comorbidities that we see frequently with people who have sleep disordered breathing, which is a great lead-in to, Guy, to the medical history, something that we should be doing, shouldn't we, on most of our patients?
Even if you just took your existing medical history and looked at it with a new vision about how some of these things are related to sleep apnea, anything listed on here is a red flag. It's a relationship. Most of them are actually cause and effect, independent risk factors for obstructive sleep apnea. So when I see hypertension, I mean, it's better than 1 out of 3 by the ResMed's latest study that they showed us that they have apnea, heart disease. All these things are just, all you got to do is look at the patient's medical history, and if you start getting check marks down on this list, they need to be tested. The test is non-invasive, and the risks are high. So, if I had a 1 out of 3 chance of having cancer, would you go get the biopsy, Rich? I mean,
Yeah, sure. And you can't have just a little bit of cancer either.
Right.
You either have it or you don't. And I like your analogy there, Guy, that the more of these that are checked on that thing, there are other countries who have healthcare systems that we're moving towards ourselves. But and if you are a habitual snorer and you have hypertension, okay, there are other countries where they don't even sleep test you.
They just give you a CPAP.
They just treat you because it's cheaper to do that. Right. So again, think about this. These are the red flags when we see this. We should raise an eyebrow and again start doing that. And why? Where do these things come from? There are a lot of studies that are done out there, and you'll see from probably 12 to 15 at the low end to 40, 45 million on the high end. So it depends on where you cut off as an adult or not an adult. But again, when we have patients who have had a significant cardiovascular event, it's much higher incidence than that. And like you said, Guy, if you just had a way in your software to go back and screen the patients who have AFib in your practice, it's every other patient, right?
A true story, my mother's significant other, I sent him home with a home sleep test last night, night before last. I picked it up today because he has AFib, and his doctors, no one really had mentioned it to him. I'm like, you've got a 50-50 shot of having this problem. To me, if you've got a 50-50 chance of having a serious medical disorder and there's a non-invasive test for it that's not expensive, what are we waiting on? And so I pretty much went over and held him down and put the thing on him, and we'll review the results tomorrow. We'll get it to the board certified physician to read, and we'll be on our way. But just look at these things, and these are the things that when you do your screening, back to the beginning of the webinar, find a way to identify these people quickly. When they have these issues, then you need to know these numbers, or your team needs to understand the relationship. That why are you worried about me? Well, I'm worried because Bob, my mother's significant other, Bob, I'm worried about you because you got a 50-50 shot of having apnea, and you need to be tested. It's not something we should mess around with. And so that's what your staff and your team need to be educated on as well. So here's some more numbers for you. Again, some of that's repetitiveness, but this was a little different. But you can see it depends, like you said, on the numbers of the age of the group and so forth. But this one, hypertension was up to 37%. Almost half the diabetics. So just big numbers.
Well, you can
there.
certainly see that there's a recurring theme there for heart issues, isn't there, Guy?
Yeah, I mean, anybody has any cardiovascular problems, they're already at least moderate, if not high risk, just from that alone. So.
And these are the people that we really can save their life. So, again, here's kind of a summary of these types of things. When we look at large neck size and clinically what we see through a Mallampati and a large tongue, and the retrognathic and the cardiovascular things, these are all the red flags that we talk about. So as you go through and review medical history and clinically some of the things that you observe, this should just raise your eyebrow towards the next step, which would be getting these patients to acknowledge that they have a problem and leading them down the path towards being tested.
Right, and if you can just get this, I would recommend you write these things down, you print this out. I'll send you a PDF if you want of it, and just get that in your head, and I promise you, if you start thinking high blood pressure, risk for apnea, heart disease, risk for apnea, large neck, risk for apnea, large tongue, risk for apnea, you start getting those things in your head, you're going to see these patients everywhere you go. your eyes are going to be open. And it doesn't mean they all have apnea, but they're at risk, and you're going to help a lot of people. So that's what we hope to do. We're also going to find people who already have this problem. Guess what? I was waiting for the bottom to load there. You know, if you just ask your patients, do you have apnea, or have you been given a sleep test? If so, are you treating it? You're going to be
you're going to be amazed at how many people, how prevalent this is, and especially for those of you just getting started in this. Right. It's really going to be an eyebrow raiser for, you know, I had no idea that these people have just been walking through my doors all this time, and I've been ignoring them. So, you know, if all else fails and you don't want to do any of this stuff, you simply ask questions. How are you sleeping? Are you tired during the day at all? Do you snore? Do you sleep in the same bedroom as your spouse does? You know, you get kicked out of the fishing cabin when you go. I had a guy tell me the other day he woke up on an airplane with a little old lady with her hands around his throat saying, "If you don't quit snoring," you know, and then everybody in the plane was clapping, you know, so ask questions.
Yeah, I should have been there with your cards. Internal marketing, so we're going to talk to our patients. We're going to screen our patients, but let them know you do this. You know, let them know you care about them. Let them know that you're getting involved and helping them with their snoring. Sometimes we have to concentrate on snoring to get the patients because that's what they care about, even though we want them to care about their health too. So starting with some of these marketing things for your patients, maybe sending a letter to all your patients letting them know that you're doing this. We put these posters up in our offices that we help train, and you know, we have a bunch of different kinds. This is one's a little bit more shocking maybe, but it gets your attention, and if you have this up and framed on the wall or in a little acrylic stand on the countertop, it gets your patients talking to you. I mean, that's what we want. We want our patients to begin some sort of a dialogue
we
with
want
us.
To engage them. We want them asking us questions, and there are multiple ways that you can do that. And again, the biggest thing is just the commitment of you as the doctor for doing that. So other social media things, you know, look at adding a sleep content to your business card, to your brochure, search engine optimization, you know, things like that. So we've gone through a lot of this in other webinars, and we'll probably do some more in the future. But you've got to correspond with the medical caregivers of your mutual patients, because they want to know that their patient is being taken care of. You know, we asked 100 doctors one time, what's the one reason that you don't refer to people? And they said, we don't know if they even show up. We don't know if they're being treated or not being treated, things like that. And, what kind of speaking opportunities are out there?
Yeah, I mean, we can talk to Kiwanis clubs. You can talk to your doctor's office, all that sort of. Yeah, and
groups.
It's an engaging subject. I mean, if you want to go talk to them about dentistry, that's great. But I promise you start talking about helping their spouses not snore, helping their spouses who can't wear their CPAP. It becomes a very engaging subject that we can go to. So there's a lot of ways of doing this. You know, there's a lot of ways of growing your practices afterwards, but start with your practice. That they're your patients. You care about them. Let's get you screening and identifying these patients. So what happens next? Once we get that, I've got the patient. I believe you. I may have a problem. What do we do next?
Yeah, well, we got to lead them down that path towards getting sleep tested. And the first part of that is really to get them to acknowledge they have a problem. I was driving down the road here in Texas the other day, and I saw a billboard, and it said 15,000 men will die this month because of stubbornness. And underneath that it says, get the test your doctor recommends. So you know, I thought it was kind of catchy, and that's part of that, you know, getting them to acknowledge that they have a problem, and then we want to get them sleep tested, and again, we want you to learn a system and a protocol for walking that patient down that path, and the next time we're going to get into the sleep test part, but you have to have a way to to deal with insurance and which devices. We love the TAP and the EMA, and Keller soon will be pushing a dorsal device out, which will be fantastic. And then we have to manage their side effects and then get them tested again, a titration test before we're done treating. But you got to have a plan for how you're going to get your arms around this whole thing and do it. But you also have to start. Don't you, guys? Right. You can't just aim. Most dentists out there, and again, we talk to thousands of dentists every year. They aim, and at some point you say, well, pull the trigger. Let's see if you even hit the target. We got to figure out. So we want to kick you in the rear and help you get going. At the same time, it's aim, shoot, that kind of thing. But we want to have a plan for this.
Right. Well, and we can help you with that. That's what we do. We are really, truly a complete solution from everything from screening to helping you get your patients tested to software, education. So feel free to email us with questions. We're not high-pressure people. Our whole team is really there to help. And we'd love to be able to help you implement dental sleep in your practice. We do want to thank Keller again for putting this on, and we're doing some courses in the fall here that I'll put up in a minute. But first of all, I'd like to thank Keller Lab for promoting this course, and we work with them. The majority of our appliances we send to their lab, and we've been working with them for years. And if you need a resource as well, you can certainly contact them. There's people there that can answer your dental sleep questions, and have been doing this for many years as well. The next webinar, put it in your calendar, is the 30th, at the same time, 8 o'clock Eastern, and we've got our patients identified, and we're ready to test them, right? And
that's the next step in this process. We do have some courses coming up. We'll leave that up here for just a minute, and remember, even as a dentist, you may be well educated in this, but you may have staff members who aren't. And nothing beats a hands-on, in-person course. And these are more introductory type things that we're doing. We do more advanced type of things in our member meetings. When you purchase a membership, basically, and what we do to help you, we do 4 meetings a year, and then we do every other week we do dental sleep study club types of things where you can get on and ask questions, and we do that. It's a nice forum for learning and things like that, and there's multiple opportunities to do this. There are plenty of educators all across the country that can help you get started in this, and we would just encourage you to open a book, or there's no shortage of things to read about in this, is there, Guy?
No, there's not, and I don't see any questions. We really would encourage. It's not a huge group tonight. I'm happy to unmute anyone. I don't see any questions coming through. If someone wants to type one through, if you want to raise your hand, I'll be happy to unmute you, and we'd be more than happy to answer your questions at this point. I'll put up our contact information while we're doing that.